Good morning, everyone, and thank you for joining us for our very special virtual leader chat. Today, our guest is Science Sam, Samantha Yammine. Sam is a neuroscientist, a molecular biologist, and a science communicator. And some of you probably already know her from her social media handles at science.sam on Instagram and TikTok, and at HeyScienceSam on Twitter and Facebook. Throughout the pandemic, she's been sharing the science behind the headlines, gathering millions of views on social media every month to help people better assess the risks, spot misinformation, and have more informed discussions with friends and family. She's an expert in vaccine confidence and risk communications and is helping fight misinformation as a member on the advisory board of Science Up First. You may also have seen her as a science correspondent for shows such as Netflix, CBC Gem, and TVO Kids, and many more. So welcome, Sam. We're so excited to have you here today.
Thanks for having me. Thrilled to be here.
It's funny, this is, we were talking just before we went live, and we normally poll our staff for questions, and we get questions live and we get questions in advance, but this virtual leader chat has hit a record number of questions from our staff.
That makes me so happy. I love questions.
They're all super excited. We're all excited. We have so many questions. This is going to be probably closer to a rapid fire VLC. We'll try and get as many in as possible. But Carla is on the line, so make sure if you have questions live as we're talking, we'll try and get those in as well. So now, because we want to make sure we get as much time in, let's dive right into today's virtual leader chat with Science Sam. So Sam, we've been in this pandemic for about 15 months now. Maybe you could start us off about what have we learned about the virus itself?
I can't believe it's been 15 months, first of all. I know we all feel that. The great news is that science has been moving and has been really moving at an incredible pace. So far, there are over 142,000 research studies indexed in PubMed, which is one of our most popular search engines for scholarly articles related to the biomedical sciences. That's a lot of articles on one specific topic related to COVID. When I say 142,000 related to COVID. What we've learned so far, we know the virus that causes COVID is called SARS-CoV-2. It has about 30,000 nucleotides, you can kind of think of them like little letters in an alphabet that make up its RNA blueprint. And if you compare that 30,000 in this virus compared to the human genome inside each of your cells, you have a DNA blueprint of about 3 billion base pairs. So it's a pretty small organism. The start of its genome goes like this. It's AUU, AAA, GGU, UUA, and together those letters code for about 30 different proteins. It mutates pretty slowly. That was something we were happy to learn. However, as we've seen, it is indeed mutating, but it's at least going quite slowly. And now we're monitoring 4 different lineages of concern or variants of concern and 7 of interest. So that's a quick summary. We know quite a lot, but there are still some unknowns, and you'll continue seeing research on this topic for quite some time.
Wow, 142,000 articles. So we know that COVID-19 has been compared to SARS and MERS. I'm sure there probably wasn't 142,000 articles written about that virus, but what makes it different from SARS and MERS?
So the interesting thing is that SARS and MERS and SARS-CoV-2 are all part of the same family of coronaviruses, beta coronaviruses, and they all lead to respiratory infections. While SARS back in 2002 to 2003 had about just over 8,400 cases, 21% were in healthcare workers, it had a higher case fatality rate. About 10% of people who got it would unfortunately pass away. But we were able to contain it by July 5th of 2003. So it did not last as long as this current one. MERS is ongoing. It has an even higher case fatality ratio, up in the 30%. So far, we've had about 2,500 cases. So the scale of these things are like many-fold different, right? SARS and MERS are both much more deadly, but because that's kind of bad for a virus, because if it hurts its host, then there's not an opportunity for it to spread. The current SARS-CoV-2 that's causing the COVID pandemic, it has this sweet spot where it's less deadly, but it's so infectious that it's causing a crisis because of just the vast number. You have a way bigger denominator of cases. So even though it's less deadly, overall, it has cause fatalities in way, way more people because it spreads so much more easily. And so that's really the challenge that we're dealing with this one, is that it has this unfortunate ability to spread. And then because it infects so many people, it can cause a lot of trouble in a lot more people than if it had been more deadly.
Wow. And as we know, some people are carrying it, they don't even know because they're asymptomatic.
Yeah, yeah.
Amazing. What about the actual, you mentioned about the mutations. What makes a virus mutate? How does that work?
So a virus, if you think of just one virus particle, that's not really going to do much. It wants to make many copies so that it can, and it actually hijacks your cells to help make more copies of itself so that it can spread and spread and spread. But every time it makes a copy, it makes some mistakes. So think about if you were copying notes off a board and you were handwriting them and you were trying to go really fast and make as many copies as you could. At some point, you'd probably misspell something, forget to dot an I, you'd make a mistake. Same thing with these viruses. As they go trying to make many copies of itself to infect more cells and then spread to more people, they make some errors. And some parts of its RNA genome are more prone to errors than others. And so as it can have these kind of somewhat random mistakes that it makes, and if they end up leading to some new advantageous behavior, let's say it allows it to enter cells more efficiently, then that mutation is going to accumulate in the population. It's going to have a selective advantage, and you're going to see more of that version of the virus spreading around because it had an advantage to do so. There's some kind of natural selection happening within these viruses, and that's why you have those different lineages. What's interesting is that we're seeing convergent evolution. And what I mean by that is we're seeing the same mutations happen separately. They're independently evolving. So it tells us that there are some parts of the genome that are more likely to mutate, and there are some and that's for biological reasons. It's less stable part of the genome. And there are some parts that confer some kind of advantage so that when it does mutate, it's going to win out and beat the others.
Wow, I hadn't heard that before. That's really fascinating.
Mm-hmm.
Amazing. Now, you just mentioned 142,000 articles. We're in this global pandemic. All eyes are on this. All we hear and talk about is COVID-19, COVID-19. What's actually happening in the rest of the medical world with other health issues, surgeries, and so on, because we're so focused on this virus?
Yeah, so according to the Canadian Institute for Health Information, and this data is actually just from last year, March to June of 2020, in Canada, surgery numbers fell 47% compared to 2019, representing over 300,000 fewer surgeries. April had the lowest number, April of last year. And so that's a snapshot. That was in the most uncertain part of the pandemic. We were most on guard. We didn't know what we were prepared for. And so I haven't seen more recent data, but I don't think it's been as bad since. However, some of you may have even experienced this, people delaying routine screening, I haven't gone to the dentist actually in a year because I've been waiting like, oh, I'll just go next month and when things go down. So even in the really small cases, I think people have been putting a lot of their personal health to the side. And I just want to make a note, please take care of yourself and any ongoing conditions and go and see your doctor. They're making sure that it is safe for you to go in and do those things. And it's really important that we do. And because it is a concern that now we'll see other things starting to creep up because so many people have been afraid to go into a health setting.
No, it's so true. Now, what about one of the terms that I've been hearing recently, because again, I just talked about some people are asymptomatic, some people get really sick, some people don't get as sick. But the one thing I've heard about are these long haulers where they have symptoms for a long period of time. So what is that all about and how is that working?
Now, this is, I'm really glad you brought that up, Nicole, because it's a really important point. A lot of people will harp on the fact that COVID has such a low case fatality rate. And I'll also say that rate changes. It's not a fixed number. It depends on geography. It depends on how bad a wave that we're in. It has changed all throughout the pandemic. So there's not one single case fatality rate. It changes depending on context. But people will say, oh, it's barely that deadly. It's actually way more deadly than the flu, for example. But there's also more to it than mortality. It is causing this type of long-term, or at least more than a month, several months for some people. So far, it's been for some people it's been a year of quite debilitating symptoms. It can include tiredness and fatigue, this brain fog some people describe, where it's hard to concentrate, loss of smell or taste. Some people have heart palpitations or chest pain, cough or shortness of breath, muscle pain, and of course depression and anxiety related to having what is a very scary virus, an infection. And so I just want us to remember that there are people who did everything that they could. It is not their fault that they acquired this infection, and it's nobody's fault, right? But unfortunately they did, and they're having long-term symptoms. And it's been very difficult for them. And I want us to keep them in mind too, when we think about, I'll be fine, I'm young and healthy. Well, some of these people had no pre-existing conditions, and now they're struggling long-term, and it's unclear what we can do to help them at this point. And so for all of those reasons, we have to do our best to limit the spread of this.
Wow. How long normally are these long haulers? Like, what determines a long haul of keeping your symptoms?
Yeah, we're still learning so much about this. There are a lot more unknowns than knowns at this point when it comes to long COVID, or PASC as it's called in the States. But for some people, it's the criteria is that it's more than a month. For some people, 13.7% still had it after 12 weeks. This is from a study out of the UK. So you're looking at multiple months, and we don't really know how long it can last because we're studying this as we go, right? So lots more unknowns than knowns when it comes to long COVID.
Okay, excellent. Well, thank you. What about, let's actually go back to COVID-19 and the origination. Do we have more science or data to actually help us understand how it was actually originating, or where it originated from?
This is a question we do not have a definitive answer to yet. I would say be very wary of anyone who's claiming with 100% certainty that they know how this started, because we don't know that answer. And the truth is, we may not know it. Right now, there are two hypotheses being considered. One is that it is from a zoonotic event. That means that it came from an animal and it passed to humans, and then it spread around from humans to humans. This is the hypothesis that many scientists believe is most likely, because that's what typically happens with these types of pathogens. And if you trace, you can look genetically and kind of build a family tree of these beta coronaviruses and look at the little, I mentioned how they mutate. Well, those mutations serve as a barcode, so you can track its history spreading through populations of wildlife to humans. And so you can build this gorgeous family tree. It's called a phylogenetic tree. If you want to see some of this, you can go to a website called nextstrain.org. It's fascinating. And you can try to see and map out where it might have come from. And when you do that, there's some pretty good evidence that it came from some wildlife and passed on to humans. But we haven't completely ruled out the possibility that someone could have been working with a similar type of virus in a lab and accidentally been infected, and then it spread from that. What I want to be clear about, though, is that if that ends up being the case, it doesn't imply that it was malicious or intentional. And I think that's the part of the conversation that often goes awry. It doesn't mean that it was on purpose or that it was engineered, but accidents do happen. There was a previous flu strain that came, I think, in the 70s from an accident like this. And so it is possible, but many scientists think that the zoonotic route is more likely. And so we'll keep seeing. The most important thing to remember is that wherever it came from, the sad part is that we were warned and we didn't act fast enough. And so next time we're warned, I hope we act much more swiftly, because it may not really, it matters for us to know, but at the end of the day, would it have changed anything? And that's, to me, the sad part.
I think we're all going to have lots of learnings that come out of this pandemic, personally, professionally. Yes. Absolutely. Now, what about surface transmission? Is that something, remember, we're all washing our groceries, guilty, I think I still do it. Is surface transmission still a concern?
This is a great question. And when we put on our scientist hats and try to think, how would you really study surface transmission? It's a really hard one to study and to trace through contact tracing and looking at case studies to see how would this have transmitted. Because in most cases where people have interacted with the same surface, they've likely also been in the same room sharing air. And so can you ever really rule out? There are some really niche examples where people wouldn't have been in the same room at the same time and just touched that same thing, but those are much less likely. So it's a really hard one to rule out. But I will say, from what we know from now millions of contact tracing, is that it seems to be a lot less likely, definitely not the main route. And so I wouldn't be worried about going to a park and, touching, I don't know, monkey bars or something. If you have kids who want to play, I wouldn't be so worried about that. For example, I wouldn't be wearing gloves in a grocery store. Personally, I never did that. It's a possibility, but it's not the main route. But I will remind you that many other pathogens do spread through direct contact like that, what we call fomite transmission. And so it's still always a good idea to practice good hand hygiene. Before you eat or touch your face, wash your hands. That's always a good idea, before, after, during the pandemic.
I totally agree. So let's talk about hand washing. Which is better, the hand sanitizer or actually washing your hands?
If your hands are visibly soiled or visibly dirty, you got some dust on them or some grease or because you were eating something delicious, in that case, washing your hands is better. But if your hands are otherwise clean, you don't see anything on them, and you want to just use hand sanitizer, that works great too. So when it comes to better, it's kind of what's more convenient. If hand sanitizer is more accessible and easier, and so you're going to do it often, then by that definition, it's better. So whatever, if your hands aren't soiled, either option's cool. Whatever gets you practicing hand hygiene is great.
Perfect. Now let's go back to airborne transmission. There's been lots of debate. Can it go through the HVAC system? Is there any data or any proof points on that?
There are some, this is an interesting one, and there's been a lot of back and forth. I don't think that there is a lot of evidence that it's traveling, let's say, between many units through the HVAC. What we do need to keep in mind is that the virus does get aerosolized, even just as you speak, and everyone can do this experiment with me now. Grab your hand, put it in front of your mouth like this, and then just say anything out loud, right? So we'll just say, hello, I'm learning today. Okay, 1, 2, 3, hello, I'm learning today. What did you feel in your hand? Nicole, did you feel?
Or moist air.
Yeah, you feel that condensation. We don't notice this, but even just speaking, certainly coughing, talking, coughing, sneezing, releases these really small aerosols, some of which can contain whatever viruses happen to be along our respiratory tract. And so this virus does get aerosolized even from talking like that, just as we felt, and even smaller ones that we may not have felt. And those can linger in the air. Now, your HVAC system is circulating air throughout the house, throughout a building. A good HVAC system will have a filter in it so that it's taking air, it's circulating it, and then it's putting it outside and bringing in fresh air as well. And it's filtering that air. And so every time it passes through the whole house, for example, it's getting filtered. And if you have a good filter, which I recommend you do, of like a MERV 13 or 14 rating, you can look this up and see what's the best type of filter for filtering viruses, then it's not really a concern that it's going to be circulating all around your house. The more common thing that happens is that there will be laminar airflow in a room. Let's say there's an AC unit on one end or even a fan, right? And if an infected person is at the starting point of that airflow, then it's moving their aerosols in one direction. And we saw this in a case in a call center, in a case in a restaurant, and it was those who were downstream of that laminar airflow in one direction that ended up getting infected. So we don't think, to summarize, I know that was a lot, we don't think it's passing around very commonly, like between units in a building, through the HVAC system, spreading, between walls in that way. But it is possible that if you don't have good filtration, that could be more likely. And if you have, one directional airflow in a room, that could be more likely. So if you are going to have a fan on and you want to increase ventilation in a room, a really great trick is open a window, and you can actually point the fan at the window to help move the air out. so that you're getting really good ventilation in the room.
Smart. Well, all 2,000 people that are watching this are not now going to sit on the other end of a fan in a closed space.
I mean, it's okay. Like, it's hot in the summer. We need fans, but just be mindful of the airflow in your room. I definitely went. I didn't ever think about HVAC ever, and I went and got a better filter. And it's helpful just for even for allergies, for everything. So now I'm always going to use that stronger filter, and hopefully that'll reduce even flu or cold spreading around in my household.
Absolutely. What about how long can the virus live airborne? That's another thing.
This is one we've continually heard about. It depends on so many different factors, so I'm not really going to give a specific answer because it depends on the humidity in the room. So if you're curious, being around the 45% humidity indoors, typically 40 to 50 is best for respiratory health. But if the room is very dry, it can linger for longer. If it's more humid, less so. And it depends also how much airflow there is. In most rooms, it's not stagnant air. The air is being exchanged. So it's not really relevant because even if it could linger, well, it's getting moved out and filtered. So that one's a hard thing. What I will mention is that transmission risk is about 18 times higher in indoor settings compared to outdoor environments. And the majority of transmission, about more than 90%, has occurred indoors. So I've been a fan of harm reduction and telling people, like, you need to see people. We're social beings. Do it outside. And just because you're outside doesn't mean that you can be up in each other's face. Be outside, keep your 6 feet distance, and have a good time.
Perfect. Excellent. One more question before we move into vaccines, because I know there's a lot of questions on vaccines. Question came in from one of our staff. Can COVID-19 cause other neurological disorders?
This is one of the topics where we're still exploring, like the secondary impacts of this virus. We're still learning a lot about. There was one study, it had just over 200,000 patients who had been diagnosed with COVID. And they looked at a variety of neurological and psychiatric conditions after the infection and in the 6 months following infection. And about 33% had something, some type of neurological or psychiatric condition in the 6 months following, 12% for the first time. So 12% of those people had no previous diagnosis. There was some incidence of hemorrhages, low, like 2%. 6 to 7% had a stroke after, 1% dementia, about 19% anxiety, and then 2% another psychiatric disorder. Can we say that all of those were from COVID? No, we don't know that yet. It's a correlation right now, and we haven't proven causation and seen how this could actually happen, and try to understand the biological mechanism, but it is possible. Certainly strokes have been seen in inpatient settings. So this virus is doing weird things in the vascular system, and so stroke, I think, is the most likely. But I also don't want to underplay like the anxiety that people who've had COVID feel because they're unaware about these long-term effects. So I just want to say, again, we shouldn't underestimate or minimize the impacts of this virus. Even though many people are fine, there are many people who aren't, and we don't necessarily know exactly who will fall into what category. Just because you feel healthy and have no prior conditions, it doesn't mean that this wouldn't create a new condition. And that's the really challenging part to communicate.
Okay, thank you for that, Sam. Okay, are you ready to switch gears into vaccines?
Yes.
Water, because I have a whole bunch of questions on vaccines.
Let's do it. This is more positive. I like this note.
Okay, perfect. So the first one, we've heard so much about herd immunity. So is it possible, and what percentage of people would it take to get vaccinated in order to actually have this happen?
Herd immunity is possible through vaccination. It doesn't happen through acquired infection. It happens, and especially not without a lot of fatalities. So it is possible through vaccination. Exactly what percentage we need to get to depends on a few factors, including how transmissible the dominant strain is. As we keep seeing infections spreading and we keep having COVID circulating, we're getting these more transmissible variants, which means we'd need higher herd immunity levels. I don't know, initially the numbers were like 70 to 80%. Now it might be slightly higher because we have these more transmissible variants. But if we can get it low enough, it may not matter. Like, we may beat out the variants. So the most important thing to focus on is that we have vaccines that are amazing. The more people who get them sooner, the lower the threshold for herd immunity will be.
Okay. All right. So next question. Person A vaccinated, person B not vaccinated. What are each of their risks of actually getting COVID?
Yeah, so it depends on which strain of the virus, or which version of the virus they're getting exposed to. So you may have heard of Alpha and Delta right now, which is going to be the dominant strain in Ontario soon. The vaccines reduce your risk of having symptomatic COVID, having some level of symptoms, probably mild, by, after your second dose, about 90%. They reduce your risk compared to someone who's unvaccinated. And it reduces your risk of being hospitalized by even more than that, depending on the vaccine, up to 96%. So when you see those vaccine effectiveness numbers or vaccine efficacy numbers, that's how much your risk is being reduced for being vaccinated compared to someone who's unvaccinated. And then remember that it's reduced risk of having COVID with symptoms, but the most important, reduced risk of being hospitalized or having severe outcomes. And so far, the vaccines are close to 100% at reducing that risk. So, like, that's great. What medication is that good? Really, way better than anyone expected. I want to be clear on that. Like, they're like AAA plus.
That's awesome. Okay, next question. And this one has been on many people's minds. The time between doses. So we need 2 doses in order to be fully effective, but the time period keeps changing. Is it 4 weeks? Is it 8 weeks? Is it 12 weeks? And it just keeps flipping. So can you give us some science and some data behind the time between doses?
I wholeheartedly empathize and also feel how frustrating it's been, especially in Canada, that we've had all these changes. And if you're annoyed by it, I'm right there with you. I get it. But I will say the rationale behind those decisions was really good. And so let me give some context. When the clinical trials were run for these vaccines, we were in a huge crisis with an unknown virus. We needed to get the clinical trials done. And so while normally with vaccines, it's typical to do a dose 1 and then a booster even 6 months later, right? Those of you with kids or who might remember your childhood vaccinations, there's usually about a 6-month between doses. We didn't have 6 months to dilly-daddle in a pandemic. So they said, let's do 1 month of an interval so that we can get the trials done, get the data, and if that works, then we can get people vaccinated faster. So it was really a logistic decision to keep the interval at 1 month. So when it came down, and then it turned out being safe and effective, and it was great. So they're like, awesome, we can get people fully vaccinated within 1 month. Amazing, 2 doses. But then in Canada, when we had supply issues, we realized it's probably just best to get as many people vaccinated as possible. We're going to stretch out that interval so that we can get more people with some protection, and that'll help us reduce the COVID numbers. And you know what? It worked. So that was the right decision. I know people were frustrated, and it's chaos booking your second doses now, I know, but it ended up serving us well, and I'm glad that we made that decision. So that's why the interval got extended. For some people, it should never have been extended. Those who are immunocompromised, they need that second dose right away. But that's the rationale and the context for why things have changed. Right now, when it comes to the ideal time gap, we don't have an answer to that. We know what we've studied, we know what we've done, we know that it's safe and effective. Phase 4 testing, which happens after, it's post-marketing surveillance, post-marketing testing, once something is in use, which is ongoing right now, that's when you decide what's actually best. But best in a crisis is what gets us out of the crisis. And we know that these vaccines are incredibly effective in any of the timelines we've been doing. So, and it's incredibly safe too. So right now, that's what's best. Maybe in a little bit of time, we'll know, okay, you have slightly higher antibodies when you do this exact 2-month interval or something. Sure, but did it have an actual difference, and did it help us get out of crisis? That's all that really matters. Best is a weird word when it comes to vaccines, because we just need to prevent this crisis.
And that's so important. It's such important context because I think everyone was thinking that the studies were changing and it wasn't. It was a decision based on the crisis and the situation in Canada.
Exactly.
So is there any data now? So we've got 3 vaccines we're using, and actually 4, because I think we're using the J&J in Canada as well. And then we have all these strains that you've talked about. Is there any data on vaccine versus strain? What's working, better than the others?
The bottom line, you're going to see all sorts of things in the news. There are going to be more variants. Here's what I need you to remember. All of the vaccines that we're using in Canada are effective against all of the variants that we've studied so far. We are so lucky. Like I can't stress how lucky we are and how really uncertain we were of this outcome a year ago. Delta is 40 to 60% more transmissible, but the Pfizer vaccine, 2 doses, 96% effective against hospitalization after those 2 doses. Oxford AstraZeneca, 92% effective against hospitalization after 2 doses. Your hearing numbers, I know there was a study out of the UK that said it's about 17% less effective. The vaccines are 17% less effective against Delta. That was when it comes to symptomatic COVID. We do want to stop symptomatic COVID as well, but remember that hospitalization and the crisis is the most important thing. And so far, all the vaccines incredibly effective against stopping that. So that's really the takeaway. What we have learned when it comes to Delta in particular is that 1 dose is not really enough. 1 dose does protect against hospitalization to a good amount, but we're still getting a lot of symptomatic COVID with just 1 dose. And that means that there's more opportunities for new variants to happen. So the 2nd dose is really, really important. It's unlikely you'd be hospitalized if you've had 1 dose, even with Delta, but you could still get an infection and that could still lead to new variants, and that's not an outcome that we want. So I just want to encourage people, think of your 1st dose as like, this is helping me out of crisis. This is protecting me in the things that I have to do in my necessary work. That 2nd dose is protecting me so much that now I can take on additional things. I can do more. So your 1st dose is the lap part of the seatbelt. Someone told me this yesterday. I love it. The 1st dose is the lap band of the seatbelt. 2nd dose is the one over the shoulder. The 2nd dose is going to let you do a lot more things with a lot more protection. But that 1st dose, it already breathe a sigh of relief. So get number 2 is the bottom.
That's a great analogy. I'm going to use that one.
Yeah. Thank you to whoever told me that. I didn't come up with it.
Okay, Sam, here's the number 1 question out there. I think you already know where I'm going with this. AstraZeneca. AstraZeneca, they're now saying you can get a 2nd AstraZeneca, or you can get either the Pfizer or Moderna. They want people to make an informed decision. Many people just want someone to tell them what to get for their 2nd dose. So what does the science say behind the 2nd doses? Mixing or keep to the same?
People who've had AstraZeneca have really had, you've been on a roller coaster. I want to acknowledge that. At the end of the day, this is a phenomenal vaccine. I am so glad that we've had it. I'm so glad the world has it. And it does a really good job at protecting because we've learned of this new rare risk of VIT, or these serious but rare atypical blood clots that can happen after AstraZeneca vaccination. NACI, who's our Canada's vaccine advisory group, essentially, there are experts in vaccines. They've said that they want to give people the option to follow up the 1st dose with AstraZeneca with an mRNA vaccine like Pfizer or Moderna, if you don't want to take on that rare but serious safety risk of it. So that's why you have the option. At the end of the day, the risk after the 2nd dose seems to be lower than after the 1st, maybe something like 1 in every 600,000 doses. So if that doesn't bother you, then you can get the 2nd AstraZeneca. Totally up to you and your comfort. When it comes to mixing with an mRNA vaccine, from early studies that we have so far in hundreds of people, not tens of thousands and millions like we have with all the other combinations, where it's the same with both doses. But from early studies in hundreds of people, it looks like following with an mRNA could give a slight immune boost, especially with T cells. And so it could be slightly better from an immune perspective but 2 doses of AstraZeneca is also great from an immune perspective. So it really comes down to what you're more comfortable with. Something with a known risk, which is double AstraZeneca, or something with a potential upside, but it's been studied in fewer people, so there could be an unknown risk, and that's following with an mRNA. There's a lot more data to digest that's coming out, and so I've actually shared a really helpful decision guide that myself and a bunch of other scientists and pharmacists and doctors and nurses have written collaboratively, and I believe that will be going out in the follow-up email if people want to think a little bit more. But the bottom line is definitely get a second dose. Flip a coin if you have to, because either option, an mRNA or an AstraZeneca, is going to be great. But getting that second dose of anything is better than only having 1 dose of AstraZeneca or any other vaccine.
Perfect. Well, thank you for that. So 2 doses, and I'm going to ask you about the third, the booster. Are we going to need a booster after all of this? Because that's another thing that we're hearing about.
We don't have an answer to whether boosters will be necessary. It comes down to 2 things. And this is what it will, these need to be answered before we'll know the necessity and urgency of a booster. 1, how long does vaccine-induced immunity last? We know it lasts at least 6 months to a year. Does it last beyond that? Well, it hasn't been long enough for us to have studied that, so we don't know yet. I'm going to bet that it does, but how long does vaccine-induced immunity last? If it wanes after a year, then we may need a booster. But the second thing is how much is COVID still spreading? And are there more transmissible variants spreading that are evasive against vaccine immunity? So if we have, so far, all the variants that we have don't escape vaccine-induced immunity. So they're not an issue when it comes to being fully vaccinated. But if a new variant emerges that is much more sneaky and evades our vaccine-induced immunity, then a booster is going to be more necessary. Here's the good news. Moderna has already started their tests of a booster. They've tested both looking at the exact same dose, so just getting a third of the same thing. And they've also made a new version of the vaccine that's specific to the beta strain, or B1351. This is the most likely to evade immunity variant that we've seen. It's the peskiest variant when it comes to evading vaccine-induced immunity, and they made a variant booster specific to that strain. And they found that even just getting a third of the same increases immunity even more, and getting this variant booster increases immunity even more above that. So we are going to have options. It may not be necessary if COVID's low enough and we have no new variants, or maybe it'll only be necessary in people who are immunocompromised or older, or living in certain regions. It's not a sure shot right now. It's possible that it's probable that it'll be an option, and whether it's urgent to take and necessary for everyone is still an open question. But the good news is it's in the works, so scientists are dealing with that, and we don't have to think about it right now.
So time will tell, and then they'll tell us.
Exactly. We got enough on our plates. Don't worry about that right now.
Perfect. Now, Sam, you talked about, we need to get fully vaccinated, and it will definitely help us not be hospitalized, and most likely help us not contract it, or at least not have symptoms. Is there any data that shows someone who's fully vaccinated, if they can transmit the virus still?
We're studying this in a few different ways, and so there are a lot of numbers to throw around. The core thing is that the real concern, we know that being vaccinated reduces your likelihood of having symptomatic COVID and definitely having severe COVID. Those are good things. That's what you said. There's a concern you could still be an asymptomatic carrier, someone who has it but isn't showing any symptoms. But the good news is that they've done swabs on vaccinated people, just swabbing the nose after you've been vaccinated for almost 2 weeks. And those who had been exposed had a lot lower levels of virus in that area than those who hadn't been vaccinated. And we think that having an infection, having replication happening in the nose is what leads to transmission. Basically in the upper airways, if you have a lot more virus replicating, you're more likely to be contagious. And it looks like the being fully vaccinated reduces how much replication can happen there. So it's way less likely that you would be contagious if you did get exposed. And when it comes to that, that's kind of looking, at the molecular level. When you look at the population level, being fully vaccinated with Pfizer or AstraZeneca, they did a study, Public Health England in the UK did a study, and they found there was a reduction in onwards transmission by about 40 to 60%. So these are early numbers. There are lots of other studies. The bottom line is that at a number of different levels, when we look molecularly and we look at the population level, what's happened, it looks like transmission is vastly reduced. And that's why we're starting to see that in fully vaccinated populations or private settings, you can safely do a lot more than if you weren't fully vaccinated.
Wow. One thing we don't talk about, and you just mentioned, we vaccinate someone in these clinical trials and then we expose them to the virus. Like, we should be thanking these people that have gone into these clinical trials, with unknown vaccines and then exposing to all these different things.
Yeah, I'll just clarify. They weren't, what you described could be interpreted as a challenge trial where you actively expose them. That isn't what happened. They just kind of let people live their regular lives, and because there's so much COVID, they were exposed. So they weren't being actively exposed, like getting virus thrown in their face or anything. But right. Yeah, exactly. It really is reducing transmission even after people have been exposed, which is what we want to see.
So there's two pieces of data, as you say, the active, and then there's what we're learning from above it. Got it.
Yeah. Yeah.
Okay, so we have just under 10 minutes left, and now I'm going to switch gears, because one of the things you and I spoke about in our prep call is how much misinformation is out there. Oh, Carla's got a question first.
I can't, Sam, thank you so much for making this very relatable for all of us, myself included. But I can't let you guys jump off of vaccines without, we have so many questions that we probably won't even be able to get to. But I have three that I'll ask you right now, kind of rapid fire. So the first one, are individuals who are deemed fully vaccinated able to interact with one another in close proximity without the use of masks or other health safety precautions?
So I have to say, defer to your local public health guidelines for that. Unfortunately, Canada hasn't given clear guidelines on what fully vaccinated individuals can do in private settings. The guidelines they've given were quite general for more public settings. I think we're going to see that. I hope we're going to see that guidance coming soon. But based off what we've seen in the US coming from the CDC, we're not seeing major concerns with fully vaccinated people hanging out without masks indoors, doing their normal thing. It hasn't led to an increase in cases. And so I think we'll likely see similar guidelines to what the CDC has put out, but we haven't received it yet. So I'm going to say stick to your local public health guidelines till then.
Great, thank you. The next question, if you are awaiting a COVID test result and have symptoms such as, let's say, fever, should you get a vaccine?
Great question. No, you should not. And that is strictly because you don't want to be exposing the people working at the clinic and other people visiting the clinic. And so the best practice is, while awaiting for a test or while you have symptoms, to continue to isolate. And then once you no longer have symptoms and you've been cleared by your local public health unit, then you can go and get your vaccination. So the reason to not get vaccinated when you have active symptoms or are awaiting a test result is because you don't want to expose those at the clinic. But if your situation's complicated, please call your local public health unit and get specific guidance, because I know there's always gray area.
Thank you. And final question before I jump off, what is the outlook for vaccines in children aged 12 and younger? If kids are not at high risk, is there a need to vaccinate this age group?
For kids 12 and up, you can already go ahead and get a Pfizer vaccine. For 11 years old and younger, we're seeing trials ongoing, and I think we'll have a lot more data on that in various age groups under 11 by the end of the year. I think that it would be really important for kids to be vaccinated, because any unvaccinated populations could now provide an opportunity for the virus to mutate amongst them. And while the risk in kids is lower, it's not zero. There have been fatalities in kids. There have been other syndromes happening in kids. MIS-C is one of them. And so I would say the risk isn't zero. And if everyone's vaccinated except them, they could be vulnerable to new variants forming. And so I think we'll get data on that soon. And I think I'm optimistic for it. And if the data look good, then I would recommend people go ahead with vaccinations of any age group that's been authorized and approved by Health Canada.
Okay, great. Now, myths, misinformation, people are nervous about getting the vaccine. All of us know different people who, either don't want to be vaccinated or fearful. What can we all say to people to help bring down that fear and anxiety of getting vaccinated?
It is totally okay and normal and great to have questions about your health, and definitely to have questions and concerns when it comes to putting something in your body. And that is a decision that's up to you to make. So I want people to know that. At the same time, I want, if you have someone in your life who's expressing these concerns, I want you to not shut them down. I need you to approach them with empathy, reach out and say, let's talk. And don't start with the data, because that's not going to be very effective. Start with, what are you really concerned about? Get to the core of what's troubling them. It may be that they've had a bad experience in the past in a healthcare setting. It may be that they had a bad reaction to a vaccine in the past. And so we can reassure them, but only once we've listened to find out what the real concern is. Now, I will also mention that there is a very organized movement of disinformation. There are people who are actively spreading rumors about vaccines, and they do this with every vaccine, and they typically are the same types of rumors. Fertility is always a target of rumors about vaccines. And so also let people know that they need to follow the money on both sides. There's a lot of money in the disinformation campaign, and there was a recent analysis showing that 2/3 of anti-vaccine content shared on Facebook and Twitter in the last year started from just 12 people. These 12 people are leading this anti-vaccine movement, making millions of dollars off it, and it's a very organized campaign. And so let people know that there are truly two sides here. There's one side of truth, but there's a lot going on, and they need to be just as skeptical of people spreading misinformation as they are of everyone else.
Wow, 12 people. That's amazing.
Yeah. It's very organized. They know what they're doing. They know how to get rumors to catch on, and it's predictable, but it's hard to stop. So we gotta pause, check before sharing. Pause and check anything that you see on social media before you share it. Do a quick fact check Google search, and then decide whether it's worth amplifying, because these people know how to get people to share. They play on your emotions. So just be aware of that and make sure that people in your life are aware of that too.
Amazing. Thank you. I want to end with a couple questions in your community, the science community. First of all, I don't know when you sleep, because it sounds like you're constantly researching and dialoguing and all of these things, which is amazing. The whole world has come together to research money, time on this pandemic. Once this is done, which is hopefully we're on our way out, what's going to happen? Will research on COVID-19 continue? Will we start to look at, other diseases, cancers? Like, what are your thoughts on that?
First, we're going to see ongoing monitoring of COVID in the community and ongoing monitoring of mutations in COVID. I don't know for how long, but I would guess at least for another year or two, until it's truly squashed. There will be scientists who are continually monitoring it and making sure that we're not getting those breakthrough variants long after most of us stop caring about it. If you want to watch some of that, you can look at cov-lineages.com. They put out reports every day. So there will be ongoing monitoring of COVID in the community, and scientists, clinicians will definitely be studying the impacts of COVID on health. Having gotten COVID in the past, what are the impacts on our health? For people who've had that, studying long haulers for a long time to come, and I don't think it'll be leaving the scientific vernacular at any point. My hope is that we've now understood the importance of wildlife ecology research and vaccine research and virology research. I hope that these areas, which have all been lost a lot of funding, will have continued funding, so that next time there's even a whisper of a pandemic, we've already known about it and we could squash it faster than we even can start panicking. So my hope is that this research is ongoing, it's continually funded. That way we don't have to be in this situation again. And all of us can play a role in that by making sure that we make sure science is being prioritized when we go to vote.
That's amazing. Well, Sam, I want to thank you so much. I want to thank you, first of all, for all the work you do and all the knowledge that you've brought to us today. I think it was really, really valuable. And we did the rapid fire, like we made it happen. That was amazing.
We did. No, thank you so much for having me, and everyone who's tuned in or watching this after. Science is driven by questions. We don't have science if we don't have questions. So all of you played a role in that scientific process and being active participants in science. And nothing makes me happier than seeing people take an interest in science. And because of that, I am optimistic for the future. So thank you all for allowing this discussion and participating, and for having me here today.
Oh, well, that's wonderful. And we're going to write an article and post it on the intranet. It's going to have some of the research that you've mentioned, as well as some other follow-ups. So thank you for that. Before we sign off, I just want to let everyone know that our next virtual leader chat is on Monday, because that is National Indigenous Peoples Day. And we have Jesse Wente, who's going to be on. He's a broadcaster and advocate for Indigenous rights and the chairperson for the Canadian Council of the Arts. So really looking forward to that. Because it's not on a different day, we're going to ask that you send your questions in by tomorrow, I think. So if you could get your questions in, we'll be able to put them forward for that. So tune in on Monday. And Sam, thank you again. That was really wonderful. I know you got a busy day to get back to, and we hope to see you soon.
Yes, likewise. Bye, everyone.
Okay, bye. Have a great day, everyone. We'll see you next week.